MRI machine costs millions of dollars. It can see inside your body in incredible detail, the bones, the muscles, the tendons, the cartilage, the blood vessels. A specialist analyzes every millimeter, reports normal, steady, no significant findings. Now watch this. A woman walks across the room. You can see immediately something is off. Her right hip drops. Her left shoulder hikes up. Her torso shifts. Cost to observe this is literally $0, but the time required 30 seconds. Information gained: which side is weak, what's compensating, how severe the dysfunction is, and whether it's getting worse with fatigue. The $1 million MRI shows none of this because the MRI shows structure. Movement shows function. And if your problem is functional, not structural, you need to watch movement and not look at imaging. But here's the problem. Modern medicine is built on imaging. Doctors order MRI, not movement assessments. Insurance pays for imaging, not detailed movement analysis. Medical training focuses on reading scans, not watching people move. So, the most valuable information for diagnostic functional problems gets completely skipped in standard medical care. So let's start with what movement assessment actually works. At its core, a systematic observation of how someone moves, not just watching casually. Systematic evaluation of movement patterns. Look for specific things, such as is movement smooth or compensated? Are there hesitations or hitches? Does movement happen in expected planes? Is there symmetry between sides? Which muscles are doing the work? Are the muscles activating? Is the sequence correct? Are some muscles overworking while others don't activate? How is the body adapting to weakness or dysfunction? What substitution patterns are being used? Which structures are being overloaded? Can they control the movement? Do they maintain alignment? What happens when they get fatigued? How do they handle single leg stance? How does movement quality change the speed? What about with added weight, with repetition, with fatigue? So most basic functional movement reveals so much about the hip, core, pelvic, and floor function. Should be symmetrical and smooth, and deviation indicates compensation. A squat tests the hips, knee, ankle, and coordination, shows core stability, reveals pelvic control, and demonstrates load distribution. Single leg stance isolates one side, so it tests hip stability, shows pelvic control, and reveals core engagement. The step down functional movement similar to stairs, eccentric control, shows knee, hip, pelvic coordination, and reveals compensatory patterns. Hip hinge should come from hip, not lower back. Test posterior chain activation, shows whether glutes are working, and reveals low back compensation. Bridge tests glutes activation, shows pelvic stability, and reveals compensation with hamstring and lower back, and demonstrates core control. These are simple movements. Everyone does them daily, but they reveal dysfunction that imaging can't see. Let me give you an example. Woman stands on her right leg. MRI shows normal muscles, normal bones, and normal everything else. What movement assessment shows is right hip immediately drops into abduction. Knee moves inward. The pelvic tilt laterally to the left. Trunk shifts right to compensate and can only hold position 5 seconds before losing balance. Right glute medius not visibly contracting. In right knee hiking up using QL, the side back muscle, instead. This tells us glute medius is weak or not activating properly. Your core instability, your core isn't stabilizing the pelvic. Body is compensating with hip flexor and QL. This creates overload on the lateral hip and lower back. This compensation is likely creating the pain. None of this is visible on an MRI. All visible in 10-second movement observation. Here's something that challenges how medicine thinks about diagnosis. 2 women, both 35, both with hip pain, both get an MRI. Women A, MRI, moderate labrum tear, mild cartilage damage, a mild bone spur. Women B's MRI is no significant findings, normal study. Question though, which women do you think has worse pain and more functional limitation. Based on MRI alone, you'd guess woman A, right? It's actually woman B. Woman A runs 5K 3 times a week, plays with her kids without limitation, pain level 2 to 3 out of 10, only occasionally, and fully functional. Where woman B can't walk more than 10 minutes, can't pick up her child without severe pain, can't exercise at all, pain levels between 7 to 8 out of 10 constantly, and severely limited. How is that even possible? Movement assessment reveals why. Women A's movement patterns are excellent glute activation, good core stability, proper pelvic control, effective movement patterns, and good load distribution. Her body compensates well for this structural issue. Movement quality is great. It's good. Woman B's movement is glutes barely activating, no core stability, pelvic floor dysfunction, severe compensation patterns, poor load distribution. Everything is overworking. Her structure is normal, but her function is terrible. This demonstrates a fundamental principle. Functional matters more than structure for pain and disability. Research supports this. Of 73 pain-free people, 73% had labral and tear on an MRI. Studies of asymptomatic adults, 9% had cartilage defect. MRI finding correlates poorly with pain severity. Functional testing correlates much better with outcome. You can have significant structural damage and have great function if your movement patterns are good. You can have perfect structure and terrible function if your movement patterns are dysfunctional. Medicine has this backward. It focuses on structure, imaging. It should focus on function, the movement, especially for chronic musculoskeletal pain. Another example, specific to pregnancy, woman, 18 months postpartum, severe hip pain, MRI, completely normal. Doctor, nothing's wrong, looks fine. Movement assessment shows 3 centimeters abdominal separation, 0 core activation during any movement. Pelvic floor coordination discoordinated, glutes firing at maybe 20% of normal, hip flexor doing all the work, compensating with back and neck, pelvic tilt anterior 15 degrees, can't maintain pelvic neutral in any position. This explains everything about her pain, but none of it shows up on MRI because the MRI shows tissue, not how they're functioning. The tissue is fine. They just are not working properly, and that requires movement to see. Let me show you specific movement patterns that reveal common postpartum hip causes. In normal single leg stance, your pelvic should stay relatively level. In Trendelenburg pattern, when you stand on your right leg, the left side of your pelvic drops significantly, which means right glute medius isn't working properly, can't stabilize the pelvic, and core isn't compensating. Glute medius gets inhibited during pregnancy. Your posture changes, it lengthens, and neutral drive decreases. After pregnancy, it becomes automatic. After pregnancy, it doesn't come automatically turned back on. Your brain forgot how to activate it properly. What this creates is lateral hip pain, glutes medius attachment, low back pain, back compensating, SI joint instability, IT band tightness. MRI shows normal glutes medius, no tears, structure is fine. Movement shows glute medius isn't functioning. That's the problem. Normal pelvic position, relatively neutral, slight natural curve in the lower back. Anterior pelvic tilt pattern is pelvic tilts forward, excessive arch in the low back, and the belly pushes forward. What this means is hip flexors are tight and overactive, glutes are lengthened and weak, core isn't controlled with pelvic position, and low back is compressed. Why this happens postpartum is pregnancy position, so your belly forward and back arch. Resist after pregnancy because the muscles don't automatically reposition. Core weakness allows the pelvis to remain tilted. You can see this just watching someone stand. Creates front hip pain, your hip flexors are overworked, low back pain, compression, and deep hip pinching, altered joint mechanics. Your MRI shows mild FAI, so the bone shape looks like it might be pinched, but actually problem is pelvic position, creating abnormal joint loading. Repositioning the pelvic often eliminates the pinching without surgery. Watch someone do a hip extension, lift the leg backwards while standing. Normal pattern shows the glute activate first, hip extends smoothly, and pelvic stays stable. Low back stays quiet. Glute amnesia pattern is the hamstring activates first, low back arch, and pelvic rotates. Glutes barely activates or activates late. What this means is that the brain has forgotten how to use the glutes properly. Hamstrings are substituting. Why this happens postpartum is because glutes are neurologically inhibited during pregnancy, altered movement patterns during pregnancy, and brain creates programs. After pregnancy, old problems don't automatically restore. It creates a deep buttocks pain. Glutes trigger points from underuse. Hamstring pain is overused. Lower back is compensated, decreased power and function. MRI might show slight small glute on affected side, atrophy from disuse. What won't show is the neural inhibition and faulty motor problem. An EMG or movement observation to see this. This one is subtle but important. Watch how someone breathes while moving. Normal pattern, pelvic floor and diaphragm coordination. Movement flows with breath, not breath holding during movement. Relax. Guarding pattern is breath holding during movement, shallow breathing, visible tension, neck and shoulder, restricted hip range of motion, and hesitation before movement. What this means is the pelvic floor is in protection spasm, nor coordinating with the breath or movement, and creating global tension and guarding. Why after childbirth, pelvic floor experiences trauma. Brain creates protective pattern, guards the area by keeping the muscles tight, and this persists even after tissues have healed, which creates a deep hip restriction. It feels like the joint is stuck. Groin pain, pain with hip rotation, sexual dysfunction, urinary issues. MRI shows nothing abnormal. Movement observation shows protective guarding patterns affecting hip function. This is about seeing the whole pattern, not just one movement. Watch someone do multiple movements in sequence. Walk, squat, single leg stance, and step up. Normal, different movements, but same good quality. Consistent muscle activation, compensation cascade. Walking looks okay initially. Squatting, some asymmetry appears. Single leg stance, significant immobility. And step up, multiple compensation, poor control. What this reveals is that initial movement use compensation that works okay. As task difficulties increase, compensation fails. Underlying weakness becomes more obvious. This explains why pain worsens with activity. Also, watch what happens with fatigue. First 5 minutes movement looks good. 10 minutes quality deterioration. 15 minutes obvious compensation, and 20 minutes breakdown pain starts. This is the loaded pattern we talk about in another video. MRIs can't capture any of this. It's a static image. Can't show how function breaks down with challenge or fatigue. Movement assessments capture it easily. So if movement assessment reveals all this valuable information that imaging misses, why isn't the standard practice in orthopedic care? There's several reasons. Medical school teaches anatomy from cadavers. Cadavers don't move. Radiology training is extensive. How to read imaging, identify pathologies. Movement assessment training in medical school, minimal. Orthopedic residency focused on surgery, imaging interpretations, and acute injury management, not on detailed movement analysis. That's considered physical therapy domain. But PT referral usually comes after imaging, after a diagnosis attempt, often after the standard model has already failed. Comprehensive movement assessment is 60 to 90 minutes. Standard orthopedic appointment is 15 minutes. Can't do comprehensive movement assessment in 15 minutes. Could do a brief screening, watch them walk, do 1 or 2 tests, but even that takes 5 to 10 minutes. Doesn't leave time for history, exam, documentation, ordering, imaging, and discussion. System doesn't allow time for that. Ordering an MRI takes 2 minutes. Generate revenue, $350 facility fee, radiologist fee, clear billing code, easy to justify to insurance. Detailed movement assessment takes about 60 plus minutes. No specific high paying code for it. Hard to justify it to insurance. But why not just order an MRI? Not recognized as a standard diagnostic test. MRI is reimbursed well. Movement assessment, it isn't. This financial incentives ordering MRI over movement assessment. MRI generates objective data, numbers, measurements, images. Radiologist report is perceived as scientific and objective. Movement assessment is observation, requires training-specific judgment. Medical culture values objective test over subjective observation. Even when the subjective observation is more information for functional problems, doctors practice with liability concerns. If you miss something and patient has a bad outcome, you could be sued. MRI provides clear documentation. We look for structural problems throughout. If something is missed on an MRI, it's the radiologist liability. Movement assessment, hard to document objectively. No images to review later. If something is missed, it's on the examiner. Legally riskier without objective backup. So ordering an MRI feels safer than liability standpoint, even if it's less diagnostically useful for functional problems. Patients often expect testing. I want to see what's wrong equals I want imaging. Movement assessments can seem too simple. You're going to just watch me walk. That's it. Patients have been conditioned to expect high-tech diagnostic. Doctors who doesn't order imaging and instead does extensive movement assessments might seem like they're not doing enough. Patient might seek a second opinion from a doctor who actually does testing. This creates pressure to order imaging even when the movement assessment would be so much more useful. So what does good movement assessment actually look like? This is typically done by physical therapists, especially those specializing in women's health or orthopedics. The initial observation is about 5 minutes. So you watch the patient walk in from the waiting room. How do they sit down? How do they stand up from the chair? Posture while sitting. Any obvious asymmetry or guarding. Gathering information before formal assessment even begins. Postural assessment is about 5 minutes, so the front view, side view, and back view. Pelvic position, spinal alignment, weight distribution, shoulder and head position, foot positioning, often photographed for documentation and progress comparison. Series of standardized movement is overhead squat. Functional movement screening is about 15 to 20 minutes, so it's a series of standardized movement. Overhead squat, single leg stand, so eyes open, eyes closed. Forward step down, lateral step down, a bridge, hip hinge, walking normal pace and fast pace, and stairs if available. Each movement scored for quality compensation pain. Then you're going to do a specific muscle test, which is about 10-15 minutes long, testing specific muscles. So your glute max strength and activation, glute med strength and activation, core activation, various positions, hip flexor length and activation, and hamstring function. Your pelvic floor screening should be about 10 minutes long, especially important for women with postpartum hip pain. Breath holding patterns, visible tension, movement restrictions, coordination with movement, internal exam, if appropriate and consented, assess actual pelvic floor strength, tone, and coordination. Detailed movement pattern analysis will be about 20 to 30 minutes long, and that's taking problematic movement and breaking them down. For example, if the squat hurts, analyze. Where in the range does the pain hurt? Where in the range does the pain start? What compensation appears first? If you correct X, does this change? What if we cue different muscles? What if we change foot positions, tempo, and load? Testing hypotheses about what's causing the dysfunction. So the functional task assessment is about 10 minutes long, and that's movement specific to patients' complaints. So if pain picking up child, have them demonstrate with equivalent weight. If pain with running, observe running mechanics. If pain getting in car, watch the movement. So the total time on this assessment is about 75 to 100 minutes. Compare this to an MRI, 45 minutes laying still, but you're not present for the analysis. Doctor appointment is 15 minutes. From MRI, structural information may or may not be relevant to pain. Specific function identified, compensation documented, root cause understood, treatment plan targeting actual problem, and baseline to measure the progress. Technology is starting to catch up. 3D motion capture systems can qualify movement patterns. AI can analyze movement videos and identify dysfunction patterns. Smartphone apps can do basic movement screening. This makes movement assessment more objective and quantifiable. But even without high-tech tools, a trained human eye watching someone move for 5 minutes will reveal more about functional hip pain than $1 million machine, because movement shows function. And for most chronic musculoskeletal pain, function is all that matters, not structural. Until medicine recognizes this, until insurance reimburses for comprehensive movement assessment, until it becomes standard care, women will keep getting MRIs. MRIs will keep coming back normal. Doctors will keep saying nothing's wrong, while the dysfunction that causes all of this pain remains invisible, except to those who know to watch movement. The answers are there. You have to watch for the right thing.